Thank you very much for the kind introduction. It's not only an honor to be here, I'm really proud to have the opportunity to lecture here at Stanford. If you have any questions, comments, just interrupt me. I speak quickly because I have a lot of things to say. I don't know when I have to finish, but you just finish me when you need to go. I have made this journey actually starting from 1989 until today, and I call it point of care ultrasound from the pioneer's point of view, because this is what I can add. A lot of people know a lot of point of care ultrasound today, but not many have been through the journey I've been through. You need to know a little bit about me, so let's take the disclosure first. Sorry, I actually do not have any disclosure anymore because I've not worked with these companies for more than 5 years now. I've worked with all the big companies because I started out in 1989, so I've been involved with all of the companies. I have some patents. I'm a partner in the USACD, however, nothing of this has ever reached me, but it's been funny, and we have had many good times. We've done a lot of good things. We think that maybe you agree on that after my lecture. Briefly, this is me in 1967, my little brother and my 3 sisters. My father, you can see, is not pretty well. He died 2 months after this trip. I wished many times if we had ultrasound at that time, because then we would probably give him some more years. My mother's contribution to focus, you will hear about that. She died 3 years ago now, but she's contributed substantially to focus. I'll come back to that, of course. But unfortunately, we didn't have it in 1970. So my father, he passed away. He had diabetes 1 and smoked 40 cigarettes a day. Not the best cocktail. Just briefly, in the sociology, 1 year, this is something that made it different from my life. That I was employed in cardiology in 1989. I did my PhD in 95 and a double PhD, which is a Doctor of Medical Science, developed in 2000. Cardiothoracic anesthetist consultant, and became the professor of what we today call point of care ultrasound in 2010. I'm an aeromedical examiner. That is a hobby business I have. That means I'm issuing healthcare certificates for pilots. I'm also a pilot myself. This is my aircraft. And I actually became an honorary professor in 2016 at the University of Cape Town, where we set up a huge program of point of care ultrasound. We did for 6 months. We did a course every week, and it's spreading all over, slowly all over Africa. I left the University Hospital 5 years ago, and my research lab was taken over by one of my PhD students. So I'm not doing any research anymore, and I'm really happy with that. But I love the clinics, so I'm doing mainly children in ear, nose, throat clinics. It's private clinics. We have funny constructions, private things, but paid by the government. So this is what I'm doing. I'm still working, and as always, I love the clinic. I think you should know a little bit about how we work in Denmark as an anesthetist, because we are not only giving anesthesia. We actually, of course, give anesthesia, but all acute. If they need a real doctor in the emergency room, they always call anesthetists. We don't have emergency physicians. So these are all anesthetists. The same you can say about intensive care. There are no doctors in the intensive care unit who do not have the basic learning in anesthesia. So you can see, we work with a lot of critically ill people. We have a Scandinavian program where we can subspecialize in ICU. That was the first subspecialty in pediatrics, obstetrics, emergency, and cardiothoracic anesthesia. So this is subspecialties we have together with Norway, Sweden, and Finland. So this is how it's set up. So if you come to Denmark, you will have to work with all this unless when you get only you specialize in it. But all the other doctors, they go through all these 3 things you see here. So what makes a pioneer successful? I've been thinking a little bit about what makes a pioneer successful. And what I come up with is that you must, of course, have an idea, and you must work hard. But that's not at all enough. There are so many obstacles which you which you will hear about. So you need a lot of luck. You need so much luck to have a good idea. So it's easier not to get good ideas than a little more wildlife. My first luck, you have already heard it. I was employed 1 month in cardiology. They gave me 1 month and they told me you will not get another month here. But I managed to stay there for 12 months, so it didn't get rid of me. And the reason I was struggling so hard was that when I saw this machine for the first time, even the image qualities were extremely poor. It fascinated me. I came from anesthesia, ICU, and emergency, so I knew from the beginning that this is the tool we need. Also in the department of cardiology, I had another luck because I was introduced to what we could call groundbreaking research. There was not much research in anesthesia at that time, but cardiologists did a lot of research. And exactly the day I entered the department, Henry Anderson, you might have heard about him when you hear the story. He's the one who invented the stent valve that we use today for aortic procedures. On a flight from the United States back to Denmark in 1989, he got the idea. And this is the first stent valve ever homemade from a pig valve put into some iron that he made on his down in his kitchen. And you can see 1989, 1990, and that was my luck because I came from anesthesia, so they needed help to anesthetize these pigs. And as you can see here, the 9th of February 19, just 2 months after I started, we had already pick number 11. So every talk is here. So without knowing it, I became famous from giving anesthesia to the first target procedure in the world ever. It was a pig, but it was the first we put it into the aorta of the pig. And then he helped me also with a lot more. I'll come back to, but what I've also learned here that innovative thinking is really hard. They could not publish this primarily work, the first work on the target, they could not publish it. It was rejected, I think, 3 or 4 times, and here's the rejection paper from circulation. And as you can see here, they actually asked for a revised version. But they finally conclude that its priority remained too low for publication in circulation. So it just tells you about how difficult it is to have such a good idea. Today, we know this is a target procedure, and I've tried to find out how many we're doing worldwide, but in Denmark, we are less than 6 million people. We are doing 1,000 every year. So I think we would say today that this is a high priority invention. Actually, he's a little bit worried about all the obstacles he's been through. So he wrote this a year ago. He wrote this how transcatheter aortic valve implantation was born in the struggle for a movie. I think it's highly recommendable to read. It's fun reading. My luck number 3, that's very important in Denmark. I was heavily supported by a charity foundation. This old widow, which I've met several times, this is when we opened our research lab, paid by her. She's still alive, 95 years old. I spoke to her son just before I left Denmark, but she's given me all that money. I didn't have anything to add except say, I think I have a good idea. I will learn ultrasound, I will teach ultrasound to everybody. And she gave me $200,000 for my first application and continued supporting me. And that meant a lot because I was never short of machines and flows. I always had the best machines and flows. So I should not ask others, cardiologists, radiologists, because it's been really difficult to work together with them when I told them that I want to teach everybody ultrasound. In addition, she gave me so much money that I had some extra money to buy extra things, also to employ people. And that's when you have an idea like mine, it's impossible to apply the foundations that normally give to the best research protocols, because I didn't have research, but I just had an idea, actually. I love the clinic. When I was in the clinic, we did that as an institute very early. We took part of this. I asked myself very often, very frequently, I are we doing the right thing? How can we know that we're doing the right thing? We don't know what's going on behind the chessboard. We just do the protocol as we learn. So how can we learn that? This actually arose the idea. Coming from anesthesia, having ultrasound knowledge, I combined this and said it must be possible to do something that is much easier, that works in another way. So I decided to make an easy algorithm for cardiopulmonary ultrasound from the outside, from the surface, that should work for all clinicians. You can call it an everyman's tool. Actually, that's it. That's what I decided to do. Today we know this very well because this is what Uber has made. This is what Airbnb has made. They make everyone, taxi drivers and hotel runners, but that was not usual at that time. That everybody should learn to do ultrasound. That was not obvious at that time. And the resistance, of course, was quite high. We don't need ultrasound. You're crazy. It's ridiculous what you want to do. And I said, no, it's not. We do need it because look here, we're doing anesthesia. We're taking care of all the critical ill. If someone needs ultrasound, we need it because we need to find out what's going on inside the patient. We cannot just rely on what we guess is going on. I'll show you today. And the funny thing is that we actually at that time we already knew that ultrasound had a huge impact because in the States in the beginning of the 80s, the esophagus ended up in cardiothoracic anesthesia. So we knew already that it's very important from an anesthetist to know if the patient on the table is he having this heart or that heart or other hearts which are dangerous not to know. So this should be treated completely different than this if you run into a hemodynamic problem. So we knew that from the esophagus it worked. And of course, it was so obvious that you can also do exactly the same from the outside. Why should we not be able to do that? There's no good reason that we should not. Except that a lot of people do not like the idea, but of course we can do it. And by the way, transthoracic versus transesophageal doesn't matter where you do it from. Just wait the easiest way. I just like to show you, if you saw that David was in red when I showed one of my first slides. So this is the first multi-plane probe ever in the world where you do multi-plane. So you might think it has always been so, but it has not started then though. But David was a Norwegian company which I worked with. And David was the one that ended up being GE target machines. All the GE target machines that came from the David 20 years ago. So all the doctor stuff we have in the patent, the machine from usually comes from Norway, outside Oslo. And I was lucky because I was listening so close to Norway. So I bought this machine. So we were the first in the world to pop this in the American society. I want to get it. 2 years later, we had the pediatric multiplane, and we did the clinical trial for the FDA approved. And it was all mechanical approach, so we have to reckon that there's a crystal that vibrates 60 times per second. It was mechanical vibration. And the multiplane, beside that, it also mechanically rotates the transducer. So it's completely different from the technology we have today. Funny story. Here you're crazy, and they might be right. I will not. I cannot say they're not right. But anyway, the idea evolved into focused cardiothoracic, what we call FATE. This is just an abbreviation. It's not my idea. This name was not my idea. This abbreviation was the editor that finally accepted our paper because he didn't like the word that we call it power TTE. He didn't like that, so we should end up the focus assist transthoracic that ended up the FATE. And it makes sense. It makes sense because we want to do hemodynamics. It's not true. As anesthesiologists, we want to do hemodynamics, and we do not want to do gas dynamics. What's wrong with the audio?
If you want to switch your mic from the right color, the left color. Yeah.
Is it too dark
Yeah.
or?
No,
Or
it's
zoom.
not because you turn that way, so the voice is projecting. Yeah, that should be.
Is it better?
It should. Is it better, guys?
Is it better?
So let's see what's in here.
Okay. So I start from the beginning. So start from the beginning. Yes.
Yeah,
Okay.
it's fine.
Okay. No, we don't want to do guest dynamics, and I think most of you have forgotten what hemodynamic actually is if you go through the physiological parameters. I just show you briefly one slide. I will not go into detail, but remember that if you want to talk preload, we need the end diastolic volume dimension of the AV. If you want to discuss afterload with me, we need two dimensions. We often forgot that. So we cannot discuss afterload unless we have two dimensions. Myocardial function ultrasound is a brilliant method to look at the myocardial thickening and endocardial movement. And we got a lot of information on diastology from imaging and from the other modalities. So you can see here that we need dimensions. This is actually, dimensions are mandatory if you want to do real hemodynamics. In addition, it may be more important to find these, because if we have a patient on the table and we think they have a normal heart and they are one of these, you are in trouble in the patient, maybe die. I think that many of the time it's so important to find out how is the status of the heart. So simply just look and see how different it looks, and then you also understand how different approaches you need to take. That's why we put it on the fake card. We never fake card. Or I have some fake cards. I don't know if I'm allowed to do it now. I got them from last week. But if you want, I have fake cards. Okay, so all the pathology you find on the fake card. So you don't need to know very much if you find the fake card. It's not normal. But it's never proved in RCTs that it works better. And I completely agree on that. Strong RCTs are still missing, but they are on their way and actually do not need so much. Because RCTs on huge number of patients, they do not tell us exactly what happened to the patient. We want to know that. So it's not enough to know that there's a likelihood of this and that. If you want to know exactly what's going on, you have to look very easy. By the way, the best study still made is a PhD student, mine was supervisor. He was a pulmonologist. He did failed long ultrasound and DVT scanning, a prospective, randomized, controlled blind trial. And what he did, he took 320 patients short of breath or chest pain, and he gave the standard care to half of them, basic skill report, and he gave the standard care plus focus in the same amount of patients. And they did an audit afterwards to find out what should the correct treatment have been. And the results are here. In the control group, appropriate treatment within 4 hours was given in 57%, and in the focus group, it ended up by 78%. It's highly significant. So from adding focus, you got much more information and you were much more correct in doing each treatment within 4 hours. And why is it so? Because when you use ultrasound, you can see what's going on. So it's a question of seeing or guessing. That's so simple. You can try, you can take your car, park in your garage when you come home, cover your eyes, do another attempt and see which one is most successful. Because this is how simple it is to see what's going on not to see. That was the name of my professor lecture, to see how much you had in 2010. So this is a patient, 43 years old, 170 kilograms, complaining about or identified peripheral edema and started to cough. He could not really take care of the women anymore, so that was the problem. And I was asked if I could help. So what do you think about this heart? Is that normal? Maybe lazy. It's easier to see here that it's not well functioning, and at least the left atrium here is too big. And if you put transducer on the chest wall, anterior chest wall, you see B lines, so there are signs of fluid in the lung. And this is the setup, and here is the patient. This was a gorilla in the zoo in Denmark. I was so scared. They have 98% genes similarities with us, but the muscle strength is 7 times stronger. So I was so lucky when the vet intubated him in a sitting position like this. They just put him down and put the steroid on so that we had time to put in the needles with ultrasound. So it was funny. We found out that he was in heart failure to some degree, and we treated him for heart failure, and he survived, but died 3 years after. This is a chimpanzee, but they asked me for a cardiac evaluation. You can see the fortune of you looks exactly as in humans. We've done giraffes, and we've done snakes, and we've done a lot of other animals. So this is something that side effect of being ultrasound enthusiast. So years ago, we had this in Denmark, published in Danish Medical Bulletin, acute anesthesia to a 36-year-old bodybuilder. He was on anabolic steroids, we knew that. Another same age almost, he had a broken arm, put into anesthesia by 2 nurses and a child. My own university hospital, this is not more than 5 years ago, acute anesthesia, 6-year-old boy, minor surgery procedure, minor procedure. And it looks pretty easy, shouldn't it be? I think you've done it many times. Yeah. But look at what happened. All of the cardiac arrest afterwards. We hear about these 2 because they survived. So they read a bulletin, the Danish case story in Danish Medical Bulletin. We wrote that because he came to our department, and this child was severe brain damage. He still is, so nobody has written about that. But why does this happen? Yeah. Why? Because it's the same answer. Because the anesthetist was unprepared for the disaster. Of course, this is the answer. Why? Because they're not evaluated. They just think this is. They just think this is just a piece of cake, and they do not really think about what they're doing. They just start out getting into the syringe, and then they end up in a disaster, and then they have to find out what to do. I've heard this guy several times and spoke to him, and one thing I remember from his lecture is that he said that clean kills on the table are unacceptable, and I completely agree. I would also say that hemodynamic crash instability on the table is also unacceptable today, because you never need to crash this. Yeah. But what was the real problem in these cases? Can you give me some ideas of what was the problem? Just shout. But you don't know the answer. Because you don't know the answer before you have looked into the patient. Let's have a look. Don't be shy. So this is the first. The heart looked like this. Severe LV hypertrophy was the finding afterwards. They managed to resuscitate it, and then the cardiologist said, well, we have a case of severe, so outcome or whatever, but severe. So when you empty a syringe with 300 milligrams of propofol for acute endogenous guy, the heart just empties. This guy ended up in our hospital on cardiopulmonary support. He had an ejection fraction of between 4 and 5 when he was drug abusing, but did not tell anybody. 2 nurses didn't understand anything. And this is pleural effusion. Very dangerous. Pleural effusion is as dangerous as pericardial effusion if the amount of the big heart. So this poor guy, he had pleural effusion corresponding to 2.5 liter in an adult, but it was missed before they did the severe brain damage today. And I'll say a little bit more about pleural effusion. Here you can see in a simple diagram what happens. So if you increase the amount of pleural effusion, the right side presses goes up and the left side goes down. You can see all the right side goes up and all the left side indicators go down. If you remove the pleural effusion, you can see the color. And this is the actually previous. This is the reflected light solid there, and you can see how it offloads. We've done many studies in that in pigs and humans. So pleural effusion decreases left ventricular freedom and cause hemodynamic compromise. This is a genetic study. We've also seen that in humans, that if you drain pleural effusion, you increase freedom. I don't think many of you have been thinking about that, but it does, of course, not mean anything if you have 200 million. But if you have a huge amount, bilaterally, absolutely fine for this. And here we published some cases where actually people died because pleural effusion was diagnosed too late. So this is extremely dangerous if the amount is big enough. And it takes me to this slide here. One thing you often forget, and I would like you to remember that if you have to remember just one thing, remember the next. Hemodynamic compromise cannot only be evaluated when it's there. So when you have a problem, you get a machine, you can get help in the machine. But you can predict hemodynamic compromise just as a difficult area. If you take a machine before, you know exactly what chances you will need. I'll show you. And I use this. I haven't, you maybe think I'm lying, but I haven't put a patient into anesthesia for a full surgery for the last 20 years without doing anything. It takes me between 1 and 10 seconds, 20 seconds, depending on, but normally you just need one window. You know what this is, there's nothing in the nothing in all the dimensions are normal, the function is okay. And I use it pre, per, and post-operative. This is the V-scan. I was involved in the development of this. This came from GE, but it was again the old Bimit company, and I was involved from the very beginning. And you do it just before you put it into the and you know exactly. And I've done it everywhere. To be honest, I've done it everywhere. This is 40,000 feet in 2009, where we do it in a Hawker aircraft. Yeah, not long time ago, I was on my way home from South Africa. We did a course in South Africa and Namibia. Airbus 380, 750 people on board. One of the passengers collapsed and they called a doctor. I had this in my hand luggage and I did this just at the emergency room. We would throw them out and do that, but we didn't do that. And they asked me, are we going to divert to Saudi Arabia? This is a nearest level. I said, no, I don't think we should go to Saudi Arabia. I think we should go to Copenhagen and I will take care of this guy. And they put my wife the first time. It was actually closed, but they opened up for my wife. And I sat there for 4 hours all the way to Copenhagen. And here you can see from the tail camera that I ordered an ambulance. So this was racing when you had. So I prevented diversion with 750 people to Saudi Arabia. I like the story. And I was happy when we reached the arm and nothing happened to me. But there was nothing really acute. I don't know what was wrong, but I managed to. My mother, she had an aortic stenosis. So here I was doing an ultrasound on her in 2008. Unfortunately, the cardiologist failed to put her into surgery before it was almost too late. I was on my way to the first flight with my aircraft. So I had just taken out of the hangar and my sister called me and said, I think mother is dying now. She'd been to the hospital twice within 1 month and now she is back again complaining about shortness of breath. So I put it back in the hangar, drove to my mother 100 kilometers away and picked up the machine from my hospital and I did the scanning in the sitting position and now she had lost half of her cardiac function, and I referred her directly to my own cardiologist for a acute replacement. She would have died if I didn't do that, but we gave her 12 more years. She died 3 years ago. This is my son. Gave her 12 more years. She died at the age of 94. Nothing is so bad. It's not good for anything. So we wrote papers on that, and we started the idea of why don't we put them down? Why don't we just do it in the sitting position? So we published that in 2010 to do faith in the sitting position, 10 seconds to achieve a subcostal view. 70 seconds to make a full fade, only 70 seconds when you have learned it to do all the windows. You don't need all the windows to really there, but you can do that. 99% of all the patients we studied, they had at least one window, so it's worth doing. You will find the heart in almost all of them. And we found out that 50% increased image quality on inspiration. And we wrote that, published that here, and we also published 2 case stories. One of them is my mother here, from life-saving phase in a sitting position. So we use it that way. So during the pre-visit, you can just put the transducer and you know exactly how the heart is. You can save these images and you can make use of these images in a way where I'll show you soon. So this is also in an aircraft, what we do in the sitting position. Here I've taken the machine to the OR. You don't need to put in an esophagus probe in the OR. And I would like to tell you what we did here. This was a very sick, very sick patient. He had chronic pulmonary hypertension. You can see his D-shaped left ventricle. He was bleeding from his bladder, and the surgeon said, we need to do an endoscopy. Nobody wanted to put me into anesthesia because of this. I said, I can do it. And what I did a pre-scan here at 9:26 in the morning. This is in 2020, so this is, all I have is old because I'm an old man. But that's how it is. It still works. And here you can see this is running on the left side of the screen in the OR. And when we put him into anesthesia, we hold a transducer onto his chest wall. So this is a real-time scanning during anesthesia induction and beginning of anesthesia. And that way we have the best reference because we have his own heart as a reference. So if he ended up in hemodynamic instability, we can watch directly on the screen what's different from this normal state. So this is the way to work because you're not going to get information, you're going to have better guidance than this. So what are we dealing with here? We are dealing with individual patient evaluation by the anesthetist using the best tool to answer the most crucial questions for a successful outcome. And let me make it clear, as clear as I can. You cannot work as an anesthetist in the near future. I will not put years in that without knowing phase, focus, or focus. You cannot work as an anesthetist in the future unless you accept to work with those guys. That's, I'm 100% sure. I'll bet on that. Just wait and see, because you know exactly, you know the patient at any inch of the patient. What characterizes, I think you know that brought to the patient performed by the provider in real time. We don't wait for the cardiologist or wait for another. We used it in a focused manner. We answered questions yes or no. And we are not fully educated, but we are enough educated. We don't need to be able to rule out all the specific cardiac diseases that we are interested in what makes the patient very sick or what might kill them on the table. Not the things that does not mean anything in critical care. If it's not so important for us, we can ask others to rule that out. In 1996, it was time for the first ultrasound hands-on course in Denmark, covered by Danish Society of Anesthesia. I was afraid of announcing it as a transthoracic, so I announced this as a TE course. That was a bit easier to consume. But I did something. I said to them, you have to scan each other when you operate the machine. And when I got the evaluation, this was what was best evaluated. They loved the transthoracic part, the hands-on part. And we switched, we left the TE courses and only made transthoracic courses after that. And you can see we're having a lot of fun. And this is just, there's nothing, this is just how it is. People there, someone who says, look at him, they're so enthusiastic. And this is really, it's fantastic to teach, and people learn a lot. And it's very simple, because what is the content? The 4 easiest way, each one on the fate count. Flora and IVC, so easy. And then a little bit of endo, that's to give a number on the right and left ventricular function. When you've learned that, you have to be able to recognize the most important methodology. You find on the fate count. That's not difficult. There are a lot of video clips where you can learn that. This is our first paper.
very difficult to publish. We ran into the same problems as in Ultrasound. Nobody would publish it. They asked for a revision, but finally, unfortunately, I have to inform you that your paper has been rejected. This was a British Journal of Anesthesia. 50 years old, they published exactly the same story. And I've spoken to one of the reviewers, and he said there was a biology among, he would not publish that. Sorry. But I don't understand because the data were really, really good. We were 3 doctors only. It was in 2000 we collected these data, but we found that images of sufficiently quality to guide hemodynamics could be achieved in 97%. We used to be 5%, and actually in 25% the information were decisive. So in 25% of our cases we were completely wrong. Most of them empty hearts running on dopamine or getting through to failing hearts because you cannot see it from the outside. So we changed the treatment in 60%. I'd say that is quite outstanding data. And here is what goes wrong for you if you don't use ultrasound. You will give a lot of inapproach to empty hearts. A lot of dopamine we did that time. I call that triple IS syndrome, iatrogenic inotropic intoxication syndrome. And you give fluid to failing heart and you will fail a lot of things. And in critical care, it's very often, remember, it's very often a combination of more than one. So you have to deal with a lot of things. So it makes it even more important. Cardiac arrest, 2006, we tried again. Guidelines came out. We suggested, that's what they should put on a 5th chain in the chain of survival, and this should be failed when convenient. And they wrote back, we don't really like its usefulness to detect, but adding it to the chain of survival, as suggested by Dr. Sloth and colleagues, would distract from more well-established fundamental interventions. 2006. A few years later, we all know it's part of the protocol now today that we should add. So it has. But that's, of course, it is. So I knew the answer at that time, but we just tried. And again, I used it already in 1989, and I would never work in a cardiac arrest situation without doing ultrasound. I want to know what's going on, because if this is the case, you will never resuscitate a patient unless you put a needle in. Why should you put a needle in if you don't have a suspicion of it? This is a patient right on the table with Cape Town just before we went into it. We went into the cylinder, and he looked a little bit, let's do a preoperative phase. We cancel the anesthesia. But if this was a cardiac arrest situation, what about this? Good to know this. It's also also from South Africa, just something we find very easily. I've used it here also. I was very close to lose my job in Norway because I didn't ask. I was not allowed to bring the machine, but I took the machine with me to see it work. And the pilot found out, but they didn't fire me. But 2 years later, I could read in the journal that now all helicopters in Stavanger, they have, in Norway, they have ultrasound now, and they save lives with ultrasound. So only 2 years later, I was chosen to be fired. It was a standard tool in the helicopters. So it's funny. So it was uphill for many, many years, but suddenly it went downhill. It took exactly 25 years before it went downhill. It was in 2014. I'll come back to that. We started in 1989. So he's a funny guy. He's the one who done all the long ultrasound actually. He's from Paris, Daniel Lichtenstein. We started out at the same time. He only did lungs, I did cardiac, and also a little lungs. I incorporated pleural because I knew that was important from ICU patients. And he's been so embarrassed that sometimes when he gave lectures about me, he asked the audience for 1 minute of silence for the reviewers that put his paper. I need every minute, so we'll not do that. And what happened? With Focus, some Italians made this. I was part of that, and we were lucky to have this published in July 2014. It was a breakthrough. American Society of Cardiology accepted this And the Europeans, they heard about that. So they did the same. So they accepted this on the 10th of April and already published 1 month later because they want to be ahead of the American Society. So in 2014, there was a completely turnaround. And look here what they write. Oh, excuse me. They write, for the benefit of the patient, the EACVI encouraged any medical professional sufficiently trained, of course you must be sufficiently trained, to obtain valuable information from focused cardiac ultrasound to use in emergency settings. So now they encourage, from being against this for 25 years, this from one day to another encouraged. It's a funny turnaround, exactly 25 years. I thought it would be there after 10 years, but it took 25 years. Then we came to special surgery. That was in 2013 when we did the first course, and then papers came out. And it's also a funny story because the reason we made the first fake course in New York was because of the fake part. Because Subas met me in Europe and brought this fake part with him to New York, and they over to Stephen Haskins, who phoned me and said, "Derek, would you like to come to New York?" That was the beginning of all the focus cardiac ultrasound in the States where we are today. So learning, yeah, a lot of lectures, but we introduced e-learning. We started in 2010 and had the first fake e-learning ready in 2012. That means that we actually have no lectures. It's extremely important that you, if you join a course, that you choose one where you have a good learning material and that are focused on hands-on. It's so easy to set up an ultrasound course where you just lecture the whole day, but you don't learn anything. You cannot learn to fly an aircraft from only reading textbooks. You must have it in your hand, and it's so important that if you look, if there is hands-on training, comprehensive hands-on training in a systematic manner. So we introduced that in 2012, and that's just briefly what we did bring along where whole body ultrasound, airway, intubation, tracheostomy, cryogenic membrane. I'm busy now. What very few and correct I've been through it, everything it can rule out on the lungs, the biggest time tool of that. So a lot of B lines, this is not normal on the anterior chest wall. There are too much fluid in the lungs when you see this on the anterior chest wall. Pneumothorax, fantastic. You can detect the separation here by the lung and the pleura. There are specific signs of that. X-ray is not good, but when you see this, and you can do it with MRI, you have the lung point, you have a pneumothorax. There's no doubt about that. Circulation, we have been through it, but this is what you can do. I just want brief to say, I use FAST more and more. I did it when I was there. I've saved life with FAST because I had a patient after a transurethral resection who had abdominal tamponade, and here you can see because there was a leakage from the catheter. And we need to drain that emergency just as we drain very few, just as we very hard few. So this is worth learning all these things, and it's not difficult. It's not difficult. And here you see a normal thing, but there was a lot of fluid in this abdomen here. Gastric, I'm not an expert on that, but it's coming in. If the ventricle is empty, you can probably give anesthesia. I'm not the one who knows most about that, but I know a lot about vascular access. And I'll say vascular access, if you don't use it, you're only good. It's fantastic. This is where I see the highest benefit of ultrasound, and I'll come back to that. So we can prevent this. That you will, when you use ultrasound, look here, it's a colleague of mine for arterial. When you use ultrasound, when you have learned it to track the immunity, and you do an optimized attempt, you never use more than one attempt. Because you track the immunity all the way into the vessel. No matter if it's a small, big, beam or artery. Look here. He tries for 10 minutes. He tried for 10 minutes. It's all lead record. It's historically published that we were allowed to lead record. Randomized control, one side, crossover one side, the standard technique that you saw here, and on the other side, I did it with ultrasound. And the data are amazing because ultrasound removes all the failures. It removes all the failures. When you never run into trouble, so there are attempts where you have 10, 15, 20 attempts. Who do not know dynamic needle positioning? You all know? Good. Because we published that in 2012. I have reviewed a lot of papers on that access, and there are a lot of papers where it's obvious that they do not control the needle tip. They have a transducer, they find the vessel, and then the needle goes in, but they don't know where the tip of the needle is. You must always know where the tip of the needle is. And just briefly, I've said that I just want you to, those of you who don't know the technique, I just want you briefly to lean back and see what we are doing here. So it's so important that you see the needle tip coming and going, coming and going. And look how big here the needle tip is. The needle tip and the needle shaft looked the same on the screen. So you must see it come and go. And if you don't see it come and go, the needle tip might be 10 centimeters further down. This is a fantastic technique, and it never takes more than half a minute to insert a needle. No matter how big, how small, or where it is, if you have prepared everything 100% and you make an optimal attempt, 28 seconds. And my colleague, he tried for 10 minutes. So I've said that we can prevent this completely. So, and it saves time. If you look at speed calculation, it saves time because it removes all the failures. So therefore, when you spend 10 minutes, you will not experience that anymore. That's why it's good to learn this technique and use. And it applies to all healthcare workers. It applies to all locations. It applies to all patients. Okay, I'll soon finish. Not much technology, but this is just my first machines. See there at home. Now we have wireless, we have small machines, we have the technology. We tried something funny 10 years ago. We went on Kilimanjaro 2010. We would demonstrate that we could supervise from Kilimanjaro. So we sent the images from Kilimanjaro to satellite and down to me in Denmark, and we could simulate that I could guide Lars on top of Kilimanjaro. This is from South Africa, where they do a lot of courses, and I get these messages very often that they really enjoy our concept. Now it's going to start in the United States. We know all that, and just the last one here, we even now read in New England Journal of Medicine. I'm not proud of that because recognition of this in 2011, I would say, is started much earlier. Effective coping cardiac arrest in 2016, it started much earlier. But that's how it is. But this is true. Possible that focus will become a standard tool for frontline clinician. And I will just say that focus represents the biggest paradigm shift ever seen in our clinical environment because it applies to everything. We're talking about a new standard. Thank you very much.
Well, I know people have to get to the hour, but if anybody has any questions, we have 5 minutes for questions, and I'll just lock it down.
I see Cesar here. Dr. Padilla, you want to ask a question?
Sure. Thank you, Dr. Sloth, for an excellent talk. As you sort of think about your experience in incorporating this and sort of being at first the lone person, right, to talk about this and sort of maybe feeling a bit ignored, if you will, what has been your experience in seeing institutional culture? Like, what's that shift that you see that we're really like, once you introduce something, you see that institutional culture sort of buy in, and then it becomes, right, you see the light, kind of the light bulbs go off. So like, in your experience looking back, what have been some effective strategies to affect culture, if you will? I think about, for example, in my field of obstetric anesthesia, TT is pretty new, right? And so there's a lot of convincing to do, if you will. So
7 years ago, I was invited to London for a personal meeting, giving a lecture like this. They didn't understand. They were about dying from suffering Cape Town to send that. And they didn't understand a word of what I was saying because they were not ready. I thought they were ready. So what makes the change
is that there is one or two enthusiasts in the environment who can go to the chief and the chief support this. If the chief's not supported, and I can say, if you want to teach people in ultrasound who do not want to learn it, it's a waste of time. So where we have had the greatest success is where there have been one or two, like Stephen, like Jan, like myself, someone who thinks like we do, this is important, and who find it funny. Because if you're 65, 64 like I am, and someone tells you you have to learn this, and you're planning your retirement in 3 years, and you prefer to play golf, you will never learn it. So enthusiasts is what drives this until it becomes more a standard. So that you think, well, of course this is a part of my education. We have had for 10 years our medical students have learned ABCD ultrasound on purpose for 10 years now, and also our training program for becoming a specialist in anesthesia. So they just take it up, but they are not, all of them are not, have the same enthusiasm, but this is driven by enthusiasts and nothing else so far.
Dr. Oakes?
Hi,
Hi.
nice to meet you. I'm a cardiac anesthesiologist and I share your enthusiasm. I trained in 2005 when I discovered really echocardiography, and I thought, why don't we use this as our stethoscope? And I think the challenge is, I believe from the very beginning of my training that we should be using this in every anesthesia, any anesthetic we do. And what I'm wondering from you is that there's a lot of barriers to the shift, in that cardiology has always had a very strong presence, and they had one paradigm for using echocardiography in all sorts of ways, right? It's a tool for tracking, and there's a certain billing structure, and there's a certain way of doing it. And what we were presenting is that no, this is a stethoscope for our care. This is something we use in real time and continuous. It's really been challenging to create a new structure for it. And even in terms of, there's a lot of pushback, like, well, if you're going to do it, how are you going to bill for it? And I think we may have to change just that whole concept. This is, just the way we wouldn't do a case about EKGs. Why, EKG monitors? Why would we not put this on? But how do you see that conversation, or how has that evolved for you?
Well, there's a second say, when the cardiologists did not believe in echocardiography done in a way, they did not believe in taking the machine to the patient. But although we call for someone who can take the patient in the bed to the lab, and it takes at least 45 minutes. But it has changed. When I started to talk to the cardiologists about point of care and the flow, they laughed at me. Today they see in my department, we actually work together, but we always compete with it. But today they see as a mistake if they have a referred patient to the acute coronary department, and they do not do a quick ultrasound including the pleura, they see this as a mistake today. So they have learned that, they have changed up the point of care. But that is, of course, that's young cardiologists. Some of them has made his PhD with me. And so it just comes from the younger, again, it comes from the young enthusiasts. The older will not really accept this, to be honest. Or even if they accept it, they will not admit it, because what will colleagues of their own age think if they accept an institute doing echocardiography. So, but it just changed slowly. I just thought that it would go much quicker. I thought 10 years, but when I can see this, everybody can see it. And everybody can see this, but it just takes much more time. But it's driven by enthusiasts, and if there are people who want to prevent it, they can prevent it for quite a long time. So that's sorry. I will bet with all of you, One day we are there, when I arrived in the emergency room, within 25 years, I'm 95 years old or something like that, I expect that there will be also some machines on those sides of me when I'm there. And I think that this is where we end up. Why should we not look into the face, see what's going on instead of trying to guess? Because this is what it makes thinking to know. And the machines, everything is better, and everything is changing. So it's only a question of time. It was taken up quite late in the United States. The emergency decision took it up, but now it's really exploding here. When ACER goes into this system, of course it explodes. Very early they took esophagus shape up, and there's no difference. Why is esophagus so important? Because it makes us look at the heart. From the inside, yes, but it's good from the outside. When this is convenient.
Any more questions?
I was very, very young attending the last 2 months. And my reflection on a lot of my training, it's the last 10 yards. We get a lot of training in how to do the exams, and we know how to do it. And then we just don't have a lot of nudges in our training to actually put the probe on intraoperatively, to actually look at it in preoperatively. And I think it's that cultural shift that most of our attendings aren't comfortable doing it. And so we haven't worked out all these tiny little problems, like, how do we do ultrasound in the middle of a C-section? Or when you're 180 in a neuro case, and I think that maybe us young attendings need to just challenge ourselves to just focus on in the OR, just put the probe on as that first step to actually see it. But did you have a way to address that cultural barrier? Is that something you saw in the shift, and any tips to kind of accelerate that change?
If I had the barrier.
Yeah, the barrier of understanding the exams, having been taught them, knowing a little bit about ultrasound, but just being willing to overcome that cognitive barrier between knowing them and actually using them every single day for every patient.
So the question, I don't know.
Yeah, no, what's the last, how to make it happen in every patient? There's a lot of ultrasound enthusiasts, and
I think the logistics.
The logistics and
ultrasound in every room.
logistics and time, and when you are at the next patient where you see could have done this better. I had my machines in my office, so when I had difficult cases, I just took them to them and then it ran through within 30 seconds. So one day there will be also a machine part of the anesthetic machines, and you will not be allowed to you will be more afraid of doing harm to the patient if you know that you can pull this out. The time will, it's only a question of time and of course that you do it. And I don't know how this is, but I did it because I had my own machine and I didn't ask anybody. I simply just did it. And that was long before that was already while I was a research fellow and had my colleagues in ICU and they probably had a patient who had we did also the TV very early because we started with TV. In Europe it was very early, but we started in the 1990s. 1992 with unit probes. So we just did it. Do it and train, use your wife, your dog, your cat, patients who allow you. There's only one way to learn. If it was an aircraft, you should learn to fly, you just fly as much as possible. And I compare these things and I say to people, you can easily let me give you the anesthesia because I give anesthesia the same way as I fly. So it's pretty safe, but I don't want to fly out.
So right now there are devices which are little probes that just hook up to iPhones and iPads. One of the things we can petition Dr. Bateman, who is not here, but Dr. Carvalho, can you convey this message to him? Which is that everyone gets one. When we sort of start the new job, and I think that would be the way to go. So no pressure.
Yeah, I mean, we're lucky to put ultrasounds in a lot of locations, which is not the same.
Yeah.
So pretty much
in the interest of time, if you have any other questions, Dr. Sloth will hear, I think with Dr. Bublik, that way the rest that have to go can carry on.
And then we're gonna focus rather in the latter part of the,
Yes,
where we can address some of the internal progress.
Yes.
Anyone who wants fate cards, very iconic fate card, I have some. If you want.